Hello, my name is Matthew Madaus. I'm the Executive Director for the Behavioral Health Collaborative of Alameda County. We used to be known as the Alameda Council of Community Mental Health Agencies. We've been around since 1975. And Tash and John asked me to share a little bit of information about the budgeting process. So I'm going to try to condense it into around 5 minutes or so to give you some kind of highlights and some of the gold nuggets that we wrestle with every year. So we do the budgeting. Typically, we started in the spring. We work with Alameda County Behavioral Health. So there's about 35 different agencies in the collaborative, both mental health and substance use providers. And we kind of take the lead from the county in terms of how much funding is available and their plan in terms of how much they're potentially going to increase contracts. All of the budgeting, by and large, not exclusively, but the vast majority of the budgeting is based upon contracts. There's a little bit of other stuff thrown in around, fundraising and things like that, but it is primarily based on contracts, and those contracts are primarily based upon funding. There are several different types. Kind of the top funding sources are Medi-Cal. Medi-Cal is the California version of Medicaid, the public health insurance for poor and disabled. Some of the providers actually use Medicare, but not many. Medicare is for seniors, the public health insurance for seniors. Medi-Cal has it's a very complicated system, but the state basically collects a number of different sources of funding from things like car license fees, a couple different types of sales taxes, and they put that into an account, and then they pass that on to the counties. The counties then use that funding to generate a match somewhere between 50 and 60% that also comes from the federal government. So it's kind of a complicated formula. So that's part of the reason we work closely with the counties to see how much that they're willing to increase contracts and what the expectations are. The parts of the contracts fall into two areas. There is the rate for services. So not all of the contracts, but many of them are rate-based, which means that you get paid a certain amount of money, say $100 for a particular mental health service or $150 for a crisis intervention service. It is typically by the minute. There are some services that are a little different. So substance use, for example, you can charge by the day or by the particular program, but it's typically by the minute. So that requires a tremendous amount of tracking and documentation to keep an eye to track down those services and justify them. And then the county oversees, did you actually write down all of the services that you provided? So they become kind of like a receipt. So in the budgeting process, there's projecting out what your costs are. Majority of that is people, is the cost of salaries and then their benefits. And then there's some costs that are related to what we call either indirect or administrative overhead. So that's things like the cost of the office, the cost of computers, the cost of contracting out IT support or having, HR staff, things like that. Much of that is fixed, and much of that continues to go up every year, regardless of whether we're actually paid for it. So that becomes one of the challenges around budgeting, is what you may need to trim back in terms of staffing or finding cheaper rents or things like that. So the projections are how much cost you have, how much is absolutely fixed, and then what you might need to trim down based upon what you're projecting out in terms of the services that you provide. Services you provide are a mixture of the number of referrals you have. So if you have a huge contract and you got great staff, but no one's actually being referred or coming through the door, then you're going to go out of business. You're going to lose all that money. So looking at, are actually people being referred? Are they coming through a certain referral source? Has to be factored into the budgeting process. The other part is how many clients actually stick with it. How many come for a couple of sessions and then drop out? Are they mandated? Are the staff really good at engaging the people who come into services? So that's factored in terms of the number of services that you'll be able to provide over the course of the year. Another piece is what's known as seasonality. So services tend to drop in the summer, particularly because kids are out of school. They tend to drop during the holidays when people are less engaged in services. Another factor is the amount of documentation time that's required, as well as travel time that gets factored in. So people sitting in traffic, people having to drive and do home visits and things like that all gets factored in. So all of that gets entered into some formulas, into Excel spreadsheets and presented to the county. And then the county comes back and says, well, we need you to do more service units, or we need you to trim down this particular expense category. And it goes back and forth and back and forth. So right now we're actually trying to make some structural changes to improve the system, but that's kind of a real quick high level overview of how it works. Didn't get into some of the other kind of less complicated funding mechanisms like Mental Health Services Act that is much more straightforward, but that doesn't apply to all different agencies. The Medi-Cal is the most common service type for both kids and adults, so that's why I wanted to give that snapshot. Be happy to be available if anyone wants to follow up with me. And if you have any particular questions, feel free to email me, or if you want to set up a meeting, be happy to chat more. My email is Matthew, M-A-T-T-H-E-W-M @bhcollaborative.org. So hope that was helpful.